Good morning, good afternoon, good evening, depending on where you're joining us
صباح
from.
الخير، مساء الخير، مساء الخير أينما كنتم.
My name is Wiswalizi
أنا
Stolemazibugo.
ويسي سيليد مازيبوكو.
Sorry, Ali, I can still hear you from the background. Right, my name is Wiswalizi Stolemazibugo from ICAN, and I bring you greetings from the Pearl of Africa, which is Uganda. Welcome to our Series 9
Recording in progress.
IPC webinar, where our focus is on the impact of pandemic on the new normal IPC. Just a few housekeeping issues before we dive into the topics for today. First and foremost, I'd like to welcome everyone. I'd like to welcome today's speakers and the panelists and also the interpreters. We have the Arabic and Portuguese translation. And whilst the French webinar happens on Thursdays at around 1100 to 1230 GMT. Please note that we will not be able to attend to raised hands, and we kindly invite you that you post your comments on the chat box. And if you have any questions, you can post them on the Q&A box, where they will either be answered live or during the Q&A session. For you to be able to receive a certificate of attendance, you have to attend at least 4, that is a minimum of 4 out of the 6 sessions, and you have to be on for at least 1 hour so that you can be able to qualify to get a certificate of attendance. The slides will be shared with you within the next 24 hours using the email that you used to register. And without getting to eat so much or spend so much on the time, I would like to first introduce our speaker for this morning, who is Dr. Abdul Wahab Omo Opeti. He is a consultant clinical microbiologist and antimicrobial stewardship and IPC physician at the Department of the Pathology of the Lagos State Health Commission. She chairs the antimicrobial stewardship and IPC committees in the Evercare and Marigold Hospital. He is a fellow of the National Postgraduate Medical College of Nigeria and has interest in AMR, in IPC, in ICU, and invasive fungal infections. He has served as an IPC specialist doctor for the Nigeria Centers for Disease Prevention and Control during the COVID-19 response in Lagos. And he also was the regional antibiotic stewardship physician in the Middle East, whilst he was working for MSF France. And he also has worked on various organizations, namely PathCare, Cleaner Lancet Lab, and has been a lecturer and consultant for the medical microbiologist at the Lagos State University. So Dr. Abdul, welcome. And he is going to give us a talk on the IPC considerations for aerosol generating procedures during the COVID-19. Over to you, Dr. Abdul.
Thank you, Lizzie. Good morning.
Good morning.
It's a pleasure to be here. I'm just going to go over a few things so that I don't take so much of everyone's time, and try to list the main issues surrounding aerosol generating procedures and the IPC considerations which are attached to it. Would I be sharing my screen, or you would have it handled over from there?
Please go ahead and share your screen.
Okay. Okay. Thank you. Let's see. Okay. From here. Okay. 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 All right, is it clear to everyone?
Yes, it is.
Great. Okay, so IPC considerations for aerosol generating procedures within this pandemic, and I mean, this is more or less looking at patients both within and outside the treatment protocols. Okay. As an outline, I'm going to be talking about this on the introduction, aerosol generation procedures, layering listed, look at a bit of policies and documents that are required and what it should be, education, communication, and advocacy for implementation, and then implementation of the IPC procedures, and a brief summary of that. So as an introduction, airborne transmission is the spread of infectious agents caused by the dissemination of droplet nuclei, which are quite small and remain suspended in the air over a long period of time and can travel long distances. Some procedures which we perform on patients are more likely to generate higher concentrations of aerosols, more than our regular coughing and sneezing, or talking. Now, the airborne transmission can occur during these procedures, which we commonly refer to as aerosol generating procedures. Now, an aerosol generating procedure is a medical procedure which can result in the release of airborne particles, the aerosols, as we've mentioned, from the respiratory tract, while administering the procedure or treating the patient, who we think, or we suspect may be suffering from an infection caused by an infectious agent, which is wholly or partly transmitted by airborne means or droplet routes. Now, these AGPs, as I put it in short, may put healthcare workers at an increased risk of exposure to not just the SARS-CoV-2, which causes COVID-19, but other infectious agents from the Ebola to the MERS and the multi-drug resistant organisms which have been with us, tuberculosis and measles. Now, these medical procedures, let's talk about them. A lot of procedures have been reported to be aerosol generating. Some, there's a consensus on them, on all parties in different parts of the world, unanimously agree that these procedures will generate aerosols. While some, there are a lot of controversies. So for those that are generally acceptable by all, we look at things like sputum induction, where we nebulize with saline, endotracheal intubation, extubation, cardiopulmonary resuscitation, the entire process, compressions, sometimes require suctions, all forms of manipulation that are necessary. The open suctioning of airways, or the respiratory tract suctioning, manual ventilations, tracheostomy procedures for insertion or removal of tracheostomy tubes, bronchoscopies. Others are dental procedures using high-speed devices. We'll talk more about that later. Non-invasive ventilation like CPAP or BiPAP. Then upper ENT airway procedures that actually require suctioning of the respiratory system. Okay, and also similarly for upper gastrointestinal endoscopy that require suctioning of the upper respiratory tract beyond the oropharynx. Then a few more post-mortem procedures which require high-speed cutting materials, and then surgical procedures also that may involve high-speed cutting within it. Now, certain other procedures or equipment within the system while in use may generate aerosol material other than the patient's secretions. So we are not going to look at those ones as a significant risk for COVID-19 if the material is not coming from the infected patient or the patient which has been in contact with that material. Now, there are several researches still ongoing. Again, as I said, there's really no consensus. Some are there consensus, some there's certainty, some we say here, there. A lot of controversies left and right. So there are still other procedures which in some places would be termed as aerosol generating procedures, while others would say, no, these are not. Okay, these procedures include, but not limited to, nebulizer administration of medications and likes, high frequency oscillatory ventilation, high flow oxygen delivery, in some parts, some tracheostomy that really do not go deep down, nasal endoscopy or some endoscopic surgeries, some flexible laryngoscopies, other surgical procedures, and the replacement of nasogastric tubes. Okay, so this, some will say no, some will say yes, and all. So let's just put that back of our mind that there are procedures still under considerations. Now, each establishment, each institute, hospital, as the case may be, should have policy documents, or guidance documents defining what aerosol generation procedures should be. They should have guidance for empirical use of transmission-based precautions. They should develop policies or adapt policies. It could be country policies, it could be international policies, as the case may be, and then put in place SOPs for transmission-based precautions. Have guidelines that guide on diagnosis, detection of suspected microorganism infections in patients, so that we could have that at the back of our mind every time we're taking care of the patients. And then equipment and supplies, the specifications, the types for different parts of the hospital, that should also be there. We should have a plan for patient preparation and what all types of PPEs should be available, what specifications, in what locations. And then criteria should also exist in these policies for cohorting patients. So if you don't have so much space as to create single room space, which we'll talk about, then we should be able to have defined criteria on how to cohort patients who will have the same infections from the same infectious agent. Okay, and then put in place engineering and environmental controls to support these precautions, which we've decided on. Now, a bit of education here and there, communication and advocacy would also go a long way to being able to implement these ICPC procedures. Healthcare workers in general should have continuous education. This is one of the system of continuous education process which is going on here with African CDC and ICAN, in which they have a lot of education on the epidemiology of all forms of infectious diseases, understand the principles of transmission-based precautions, type of precautions, transmission routes, and the likes. They should also be trained on correct and rational use of PPE, how to don, how to doff, when to use what, how long to use it, the right type of PPE for what kind of scenario. Now, healthcare workers also should be trained on waste disposal, understanding how to dispose of the waste, generate the waste itself, how to move from one point to the other, and then can have signage, which talks about this at different points, reminding people this is what should be done. Oh, this waste bin is for this, that is for the different color codes, what the purposes which they said, should have that also around. And then you should have communication tools.
Fred is on the call. I don't know, Fred, if there's any update on sequencing you want to share?
We should also develop appropriate communication messages and tools, okay, for patients. So patient education is quite important. Inform patients or relatives on IPC measures in which they have to, precautions which they have to take while coming into the hospital setting or the healthcare setting. Now, to go into implementation, one of the things we have to look at first is our risk assessment. Assess exactly what kind of disease we are dealing with. This kind of patient, what do we suspect that the patient may have? Are we thinking the patient would have an infectious disease? And therefore take a decision on where we want to place the patient, what kind of scenarios which surround, is it in the emergency, is it the ward, and then what procedure we want to. We have to think about, at that point in time, what kind of precautions. So is it just contact precautions? Is it airborne precautions, the droplet precautions? Those are considerations which we'll look at and assess and decide on which kind of precautions. Once you conclude that you need to implement airborne precaution, then you decide on how to go about that. So if you have your patient coming, okay, these procedures are best performed in an isolation, okay, if they are available. Because again, I do not expect all establishments may have isolations which are well designed for that. Some may just have rooms which they may modify to suit these purposes. And if we don't have so many rooms, if you have a large hospitals with several beds and you require to perform these procedures, it will be important that we prioritize the patients that actually need the procedures to be placed in such a room, or those who have higher risk. Okay, so these rooms could be single rooms with negative pressure, as we know, having air exchanges of a minimum of 6 air exchanges, so about 12 if you can design it, to fit. Okay, now air from these rooms, can be exchanged through the HEPA filters, and then before they move back either into circulation or out of such a room. With such a room, it's best we always keep the doors closed. Okay, and then at any point in time we're performing the procedure, the doors should also be closed. Now, legacy pressure, of course, is best. However, if we do not have that, a standard room could be used, okay, where we are sure of at least a bit of natural ventilation, have open windows, or a scenario where we know that only a few people, that's only those required, would be in the room, and the doors would always be locked. Okay. Now, a positive pressure room is definitely not an option. I mean, that's going to blow out the air containing aerosols back to circulation within the hospital space or the corridor, where you may have patient-related waiting area and other patients present. Of course, if cohorting is necessary, I mean, a large emergency room, having 2 or 3 patients and you need to perform the procedure, it would be nice to have a bit of shield and, and a cordon off, sort of, so that you can have the process done if necessary at that point, if it's life-saving. Okay, so these are some of the ways we can design and think of how to put our patients, based on our needs and what we have, the resources available to us. Now, to take a look at the procedure proper. Okay, we should have the required number of people for that procedure available. Anyone who doesn't need to be there doesn't need to be there. This is reducing the number of people who are at risk or exposed. Okay, and if, of course, we can avoid performing this procedure completely, yes, we should. However, if we cannot, we also look at alternatives for eventually, if we have to perform, we have to perform it. Okay, and this is not the time to have a lot of visitors, patient relatives coming into the same room while we perform these procedures. Okay, we should, all the healthcare workers involved, should wear the appropriate PPE, which we'll talk about. And then we'll also have to be, this is where we talk about having the right skills also, and also making sure we not fail at whatever we do. So for example, if you're attempting to intubate a patient, having failed intubations will lead to several suctionings, and then we are generating more aerosols, spending more time within the space, and reattempting and reattempting. So this is one of those times that you have to really be very good at what you do and ensure that you get it right the first time. And therefore, we'll also we'll clean once we're done with the procedure. Okay, PPEs. Now, because again, as I've mentioned earlier, that we have, controversies, lists of those who believe here, those who do not believe there. It's safe to assume all those on that list may generate. It's safe to do that. It's safe to be, to assume that and then to be sorry. Okay, and based on this, the best way is for us to have N95, on as the minimum masks we use. Now, if you have, powered air purifying respirators, if your system can afford it and is available, and you need to use it for extended period of time, within and where you remain within the space, in which the procedure is performed to take continuous care of the patient, yes, sure, that can be used. Now, where there's almost nothing, I use the word almost nothing, the minimum that can be allowed at least is to wear the surgical mask and have it properly worn. That's the least that can happen. Where you say, oh, there's no this, there's no that, there's no this, the minimum at least is a surgical mask while performing such a procedure. Okay, other things that are needed, high protection, goggles, the face shields, wearing a gown, preferably one that is fluid resistant, long sleeve, okay, and then the use of gloves, okay. Now, depending on the supplies you have, you can prioritize which PPEs will be used for which procedures, what scenarios. This all comes to the facility policy as mentioned earlier, Okay, and if extended use of some of these PPEs are required based on shortage, this will be defined on what to look out for when you decide to change or you have to change such PPEs. Now, after the procedure is done, of course, we expect that there are going to be aerosols here and there, some drop on surfaces. So we expect that we do proper environmental cleaning and disinfection. This is crucial, even routine, for preventing transmission of infection within the healthcare environment. Ensuring that these procedures are followed consistently and correctly is quite important. If we have medical equipment for the patient, where we can afford it, we can have dedicated equipment for that patient. However, if there are equipment that cannot be dedicated solely to patients and have to be shared, we have to understand we have to clean this equipment, disinfect them properly while we use them between patients. Okay, and the entire room itself, would always remain clean. Of course, the routine cleaning must take place, the daily cleaning, okay, which involves cleaning and disinfection with appropriate agents as defined by policies which are available either in the facility or locally or nationally. And then the end of care of the patient eventually gets discharged and moved out of the room or moved out of the space where the procedure was performed. Of course, there has to be a terminal cleaning, which is more thorough than the routine cleanings. All components within the personal effects of patients, all things adjustment, the curtains, the lightnings, and all of these are well cleaned. Okay, so again, just as we said, I remind of our previous trainings of steps for routine cleaning, okay, getting our supplies ready, performing our hand hygiene and clean area and disposing of properly, and performing hand hygiene at the end of the process. And for terminal cleaning, change of supplies will always come in the bathroom, the floors, proper cleaning and disinfecting will always take place before disposal of the waste. Therefore, all furnitures, everything around within the space where the procedure was performed should be thoroughly cleaned and disinfected. If it's a procedure room, say you have a CT scan room where you have an interventional radiology procedure that requires intubation of the patient was intubated and requires suctioning while the procedure is being performed. All the spaces should always be cleaned before the next patient comes in, okay, based on policies available within the hospital. Then you have all the spaces required, following manufacturers' instructions for each of the components to be cleaned and disinfected. Of course, laundry, food services, and electrical waste should also be performed according to the policies and should done so, and that should be done regularly. Now, the linen itself, do not expect in a case where we've had procedure done on patients, the linen or the fabrics of patients should not be agitated. If we're going to fold this, we're going to do it gently. We do not want to, get these aerosols back up in the air for those who have settled. Okay, and therefore, to be nice to have them packed well into a bag and then moved gently to the appropriate location for cleaning and laundry. Okay, now for waste, we should not forget our principle from the cradle to grave generation to the final disposal. The policy still applies, the principle is still there. Okay, we should have guided policies and SOPs for segregation, transportation, and storage of waste, so that for the aerosol space, for the space, whether the room, the emergency, as the case may be, or wherever it may be, once an aerosol generating procedure is performed there, we should have guiding documents on how to handle such waste and dispose of such waste. And remember to continue using our color-coded system for separation for our waste bins. Again, the environmental cleaning, as I've highlighted, the bed rails, the drip stands, okay, the different parts of the equipment which are common to patients, frequently touched parts should also be cleaned frequently. Now, in dental practice, I did mention that there are few procedures which are aerosol generating procedures in dental practice. Where you use high-speed dental handpieces, ultrasonic scalers, and the like. This generates aerosols. So one must decide, really, does this patient need the procedure? And if patient needs the procedure, then one should begin to consider if it's going to be aerosol generating or not. And while that's happening, then we need to plan ahead for it and decide how we assess the risk, and then have only those who need to be in the room to be in the room. So you do not have to, limit the numbers to exactly dentists, dental technicians supporting within the space where the procedure will be performed. Of course, we can use all kinds of devices, to reduce, dental dams can help minimize, droplets pattern and aerosol generation. So all means possible to reduce the aerosol generation can come into place. Again, PPEs are important. Wearing the appropriate PPEs from our respirator N95 to high goggles or to the face shield, to the gown, to gloves are quite important. Of course, this is not the time to have the visitor, while performing the procedure, having the visitor or patient relative to be in the same room, with the patient. In summary, we looked at the airborne transmission, examples of aerosol generating procedures which generate aerosols. We talk about the need for policies to be present and the education of our healthcare workers to understand what is needed and what is required of them for each of the procedure, how to assess the risk and how to implement these precautions, airborne transmission precautions at any point in time. It's also important to develop and implement a monitoring system. So even though, yes, we've had policies in place, we've educated our colleagues, and then we also need to have a bit of evaluation and monitoring to ensure that these processes are complied with at every single point in time, to reduce transmission within the healthcare setting. Okay, thank you for listening. These are the references. Thank you, Lizzie. I'm done with my presentation.
Thank you, Dr. Wahab Etu, for that very informative and very insightful session on the IPC considerations for aerosol generating procedures. You walked us right through the IPC issues when it comes to patient placement, when it comes to ventilation issues, and more so when we're carrying out the aerosol generating procedures, which is really, really good. And also thank you so much for giving us an overview of the standard precautions and how they get to apply when we're performing the aerosol generating procedures. And before we move on to our next speaker, we're just going to take a 5-minute health break just to ensure that our interpreters can catch a breather. And so please stay logged on, and we will resume in the next 5 minutes. Thank you so much, Dr. Etu.
Thank you, you're welcome.
Thank you. Dr. Etu, may you kindly stop the screen share?
Okay, yes, please.
Oh, yes, all right, thank you. Right, welcome back, everyone. We are now going to move on to our next presentation, which is on ventilator-associated pneumonias. Please help me welcome our next speaker, who is going to talk to us on about ventilator-associated pneumonia. The next speaker is Dr. Chizoba Peters. She's an anesthetist and intensivist with over 20 years of critical care experience. She is currently the Director Clinical Services at Marigold Hospital and the Critical Care Center in Lagos, Nigeria. Dr. Peters, over to you. Welcome.
Good morning, good afternoon, or good evening, everyone, all around the world. I'm so honored to be here with you all, giving this presentation on ventilator-associated or ventilator-acquired pneumonia. I'm going to start sharing my screen so that you can see. There we go. Fantastic. Can everyone see my screen? Sure you can.
Yes, we can.
Great. So, good. So, as said earlier, I am Dr. Peters. I'm the Director of Medical Services at Marigold Hospital and Critical Care Center. We're here in Lagos, Nigeria. We've got a 5-bed ICU and a 2-bed HDU. This hospital has been in existence for 3 years. Prior to that, we worked out of several different hospitals in Nigeria, delivering critical care to different parts of the country. So I'm just going to start by talking about the things we should know about VAP. So just to keep it simple, I'll just call it VAP, ventilator-associated pneumonia. Okay, it's a hospital-acquired pneumonia. It occurs after 48 hours of mechanical ventilation. So if a patient comes in with a community-acquired pneumonia and has to be on the ventilator, it is not a ventilator-associated pneumonia. It's not a VAP. Now, it's quite common. It's a common complication of mechanical ventilator, and it's one of the common nosocomial infections that we see in the ICU. In the United States, you have about 2 to 16 episodes per 1,000 ventilator days, which is, that's quite low, to be honest. But we find that in other countries, in developing countries, in Asia, even here in Nigeria, the incidence is probably more closer to 3.5 to 46 infections per 1,000 mechanical ventilation days. And obviously what that means for us is that it increases the length of stay in the ICU and in the hospital. It increases morbidity and mortality. And it's a very expensive infection to have because obviously, you start needing more expensive antibiotics. And then you can start seeing more multi-drug resistant strains in all these things. And as I said, it's one of the top 3 most costly nosocomial infection diseases worldwide. So what's the pathogenesis of VAP? So basically what we've done by intubating a patient, putting a tube in the patient's trachea, is that we have created a foreign body, we have put a foreign body in the airway. And as you and I all know, foreign bodies are the easiest ways to get any infection. So where is the reservoir of these infections? So we have the oropharynx, the nasopharynx, and even the stomach. And what happens is that patients start micro-aspirating without us even knowing. Fluid comes up from the stomach, down from the oropharynx, from the mouth, down to the cuff of the endotracheal tube. Now, the cuff of the endotracheal tube is a high volume, low pressure cuff. And what that means is that we then start having ridges in the cough, causing these secretions to seep gently down into the trachea. So first of all, the secretions are pooling there, and then they start seeping into the airway. And that's what we refer to as microaspiration. And this causes colonization of the upper respiratory tract, and then it goes down to cause a ventilator-associated pneumonia. We also have the problem of a biofilm forming over this endotracheal tube, and these organisms just staying, waiting to manifest in the middle, in the inside lining of the endotracheal tube. So this is basically how it happens. And if this problem has been here for so long, why is it still raging? Why is VAP still a problem? Well, the truth is, many times these patients are so sick, they had a fever before they came, probably they already had high inflammatory markers. And when a new infection comes on, sometimes we don't think that's a VAP, we don't even remember that that's a possibility. So there's a low index of suspicion. There are no clear gold standards for diagnosis, okay? So it's not like if a patient has a pulmonary embolism, I do a CTPA and I see and I know. And sometimes you may not have done a lung imaging of the patient prior to them being intubated. They might not have been intubated for a respiratory failure that was caused by a pneumonia. So you probably didn't have a chest imaging done, and you're now not sure if it's a VAP or the patient had something already brewing. Another problem is antibiotic resistance. We have a lot of antibiotic resistance now. Multi-drug resistant organisms are creeping up in different parts of the world. And so it's harder to treat a VAP knowing full well that the organism colonizing the patient's respiratory tract is likely going to be a tough one to battle. We are often doing things to the patients. There are always procedures going on. If it's not intubation, it's an NG tube, a PEG, and all these things that we do to patients increases the risk of them developing a ventilator-associated pneumonia. And of course, we have the almighty COVID that burst into the scene, changing things forever. Now, who are the usual suspects? Well, most of these organisms are gram-negatives. Those are the ones who cause these nosocomial infections, but we also have gram-positives. And very troubling, we have Candida species as well, showing up and disrupting things. Recently, we've had quite a few, 3 cases, and that's 3 too many, of patients with a Candida albicans in their respiratory tract. So what did COVID change? Well, one of the good things, if we can say that COVID did was it made healthcare workers more likely to use PPE when approaching patients. So everyone would put on their mask and put on a face shield. What it also did was make us insist on doing a chest imaging for all the ICU patients. And we were now in our facility, we started isolating. We used a separate room for patients who came in with any respiratory pneumonia. So we would try and isolate them from the other patients. What that did for us was help us to figure out patients who already, because sometimes we have patients, the poor history transferred from another center. We're not quite sure where the infection is. They come down with sepsis. So doing the chest CT helped us realize who came in with COVID and who, or had a community-acquired pneumonia, or even a nosocomial pneumonia from the referral center. Now, in Marigold, we do not manage patients with COVID. Because our hospital, we only have this one facility, and we don't mix non-COVID patients with COVID patients. So we end up referring them to hospitals that are dedicated to managing patients with the COVID pneumonia. Another thing that COVID changed was that it now made everyone suspicious. Every pneumonia is COVID until proven otherwise. And what that probably does is it delays treatment time, because sometimes patients, they have to do the PCR test, they have to do a chest CT, and then, confirm all these things before treatment is started. So what are the risk factors for developing VAP? And this is very important because clinicians must know the risk factors. So we have a high index of suspicion when patients have symptoms. So first of all, advanced age, of course, because we know that the elasticity of the lungs is less, their ability to clear airway secretions are reduced, and they are more likely to have comorbidities, diabetes, hypertension, even malignancies, okay? Patients who have prolonged hospital stay for whatever reason, patients who have been in the hospital for a longer time are, of course, at a higher risk of developing ventilator-associated pneumonia. Prolonged mechanical ventilation is top on the list. Disorders of consciousness, because these patients will still require some airway manipulation, either an endotracheal tube or a tracheostomy. Previous antibiotic use, especially when it comes to the presence of multi-drug resistant organisms. Burns, major burns, have a higher risk of developing ventilator-associated pneumonia. And we found recently, studies have shown that significant smoking history actually puts patients at higher risk of developing VAP. Invasive procedures, as we said. And there's some talk about gene polymorphism, which might be a bit esoteric, but some studies have shown that. So how do we recognize patients with a ventilator-associated pneumonia? First of all, you're obviously going to look out for signs of a pulmonary infection 48 hours after the patient have been on the ventilator. So you're talking about a fever or even hypothermia in elderly patients, so immunocompromised patients. Purulent secretions when you suction the tube, leukocytosis, and a new rise in procalcitonin. Procalcitonin is a good indicator of infection in our ICU patients, and we use it quite often. Obviously, bacteriologic evidence of a pulmonary infection, so you'd be taking a tracheobronchial aspirate or a bronchoalveolar lavage to check for these organisms. And obviously, you can also do a radiologic investigation, a chest X-ray, chest CT, to confirm that indeed you have signs of a pneumonia. Now, in ICU patients who have, they're connected to the ventilator, they've got multiple drips and things around them, and movement is cumbersome, and maybe you don't have a mobile X-ray machine in your facility, you can also use the lung ultrasound for diagnosis of VAP. Now, obviously, sensitivity and specificity will be very low, and it obviously depends on the user's experience with lung ultrasound. But you can find air bronchograms, and you can actually see evidence of a pneumonia in a patient. So, brings us to prevention. Now, what do we do to prevent the ventilator-associated pneumonia? The truth is, the first thing you should do to prevent a VAP is to try and reduce the incidence of invasive ventilation. So if amenable, you can start by non-invasive ventilation. So you can do a face mask, a hood, intranasal, high flow oxygen, whatever it is, to try and delay putting that tracheostomy tube in the patient's trachea. If you can do that, then you would have won. Okay? What other things can we do? Obviously, the obvious things are still very important to do. Proper hand hygiene, washing our hands properly before we touch them. Don't forget the 5 moments of hand hygiene. Before you touch the patient, after you touch the patient, patient's bedside, before you do a procedure, very important. One of the things I have found to significantly reduce the incidence of VAP is actually adequate staffing. Now, in the ICU, the nurse-to-patient ratio, it should be a minimum of 1:1. And where you have situations where one nurse is nursing more than one patient, that nurse becomes a carrier sometimes from one patient to another. And then you start, proper hand hygiene and the use of PPEs and things like that start slipping. You don't want that to be a problem. You want to make sure that you staff your units adequately to make sure that one patient is nursed by one nurse. And sometimes in patients who are very dependent and require a lot more, You may even have 2 nurses nursing 1 patient. So it's very important. That's where the admin, there's an importance of governance in all these things, because you have to decide on how best to staff your units to make sure that you have adequate staffing to reduce the incidence of these sort of problems. Now, the suctioning debate I wrote there, it's about when are we actually supposed to suction the patient. As Dr. Etu had earlier said, suctioning is an aerosol generating procedure. It is something that we don't take lightly in the ICU. But remember, you have put a tube in the patient's trachea, patient is sedated, not able to cough up their secretions, and they are going to generate secretions. How are we supposed to, when are we supposed to suction patients? Disconnecting the circuit to suction with an open suction tubing is not advised. When you're suctioning the patient, you should make sure that you use a closed suction circuit. And if you do not have a closed suction circuit to use, then you have to do it as a sterile procedure where sterile gloves, use a single suction catheter and dispose of it immediately. The other thing is instilling saline through the tracheostomy, through the endotracheal tube or the tracheostomy tube. This is not generally advised. Previously, it was done because it was thought that the secretions might be too thick and viscid and won't be able to be suctioned out with ease. But we find that if we nebulize the patient with just saline frequently enough, we'll be able to suction the airway without instilling fluid into the airway. Now, the VAP Prevention Bundle is something that has been known to all ICU staff for many years now. And it includes what we call the fast hug, fluid management, adequate analgesia, sedation breaks, thromboprophylaxis, keeping the patient's head of his or her bed at 35 degrees, ulcer prophylaxis, and glycemic control. But the truth is that not all these things directly reduce VAP. They are sensible to do, and they are important to do for all the patients in the ICU who are intubated and ventilated. But correlation is not always causation. For example, thromboprophylaxis reduces the risk of a patient getting a DVT and a pulmonary embolism, but it does not reduce the risk of ventilator-associated pneumonia. Rather, I think some of the things that should be emphasized are things more like oral care, suctioning the endotracheal tube, and suctioning the oral pharynx to reduce the pooling of secretions around the cuff of the endotracheal tube. So we've talked about the closed suction unit. These are the sort of closed suction tubes that we use, and these are the open suction tubes. Remember, it's preferable to use the closed suction tubes, but remember these have to be discarded every 24 to 48 hours. Trust me, it's cheaper to buy the closed suction tubes than it is to buy 1 vial of carbapenem. So, does early tracheostomy help? Should we put a tracheostomy in patients early if we think they're going to require prolonged ventilation? Well, the studies have shown that this actually does not reduce the risk of getting VAP. Rather, it's, the results are equivocal. So the other things that we have mentioned are more important to do than actually putting in a tracheostomy early in patients to reduce the risk of ventilator-associated pneumonia. So I want us to talk about subglottic suctioning. So we've talked about suctioning through the endotracheal tube, but one of the things that we have seen now to reduce the risk of ventilator of VAP is subglottic suctioning. There are new endotracheal tubes now. Some of them are lined with silver, some of them are not, and they have an extra port for suctioning, so that the secretions that gather around the cuff can be continuously suctioned away from the patient's oral pharynx to reduce the risk of these constant micro aspirations. This is very useful and very helpful. And even if we are not able to do constant suctioning, we can do intermittent suctioning to make sure that this area stays dry. Word of caution, though, is that the suction has to be low pressure, because you cannot afford to have a high pressure suction here, as it will cause damage to the tracheal walls. I've also just mentioned silver-coated endotracheal tubes. We've found that studies have found that using silver-coated endotracheal tubes can reduce the risk of ventilator-associated pneumonia. At this time, we do not have access to silver-coated endotracheal tubes in our facility, but definitely if you do have access to them, it's worth giving it a try, and just watching and obviously auditing to see if there's a reduction in ventilator-associated pneumonia at your center. So in summary, I've just spoken about ventilator-associated pneumonia. Remember that it's caused by pooling of blood, of secretions in the airway gotten from the oropharynx, nasopharynx, and even from the stomach. We can prevent ventilator-associated pneumonia by following the normal IPC protocols, wearing our face masks, washing our hands, ensure adequate staffing, ensure that patients are sat up in their beds, with antibiotic stewardship, so we don't increase the risk of multi-drug resistance organisms. Thank you very much for listening.
Thank you, Dr. Peters, for that very informative and insightful session on ventilator-associated pneumonias, and also how we get to implement the bundle, and also getting to give the country perspective. So at this point of time, we are going to move to our question and answer segment, and I would like to welcome our panelists for today. And they are from WHO, they're from Africa CDC, and also our speakers for the sessions today. And whilst our speakers are getting a breather, I would like to first address a question on the chat box, which deals with when we're going to get the presentations. As earlier on said, the presentations and the recordings of this session are going to be posted to your emails that which you used to register. So you will get them within the next 24 hours. Please make sure that you read right through the email, because that is they are posted towards the end when all the rest of the other information has been shared. And then my first question, I'm going to direct it to Dr. Barasa. Dr. Barasa, welcome. My first question to you is, may you please explain the decontamination and disinfection? Is there any difference, or are they similar? Over to you, Dr. Barasa.
Yes, thank you very much. So decontamination reduces the microbial contamination of materials, and yes, and it's through the use of disinfectants. So disinfection as well is accomplished through the use of chemical disinfectants. So they are more or less similar. It's the sterilization that leads to the destruction of all microbial life. But for both decontamination and disinfection, it's about reducing the microbial contamination by materials. So maybe that is what I have to add, unless there are any other additions from the team.
Thank you, Dr. Barasa. Any additions from the team of panelists? Right. Thank you so much. And my next question is directed to Dr. Abdul Wahab. Dr. Wahab, this question is for you. If there is no airborne infection isolation room, is it acceptable to then do the procedures outside where there is good ventilation? That is depending on the patient's condition. So if the patient's condition does not allow, what is the next step? Over to you, Dr. Wahab.
Okay, thank you, Lizzie. Now, again, I think the first thing has to be considered is the risk. Individual risk assessment must take place to take a look at the scenario. What kind of patient you have? Is the patient, is the diagnosis of infective cause? That's again guide to deciding what else you want to do. With the advent of the COVID pandemic and all the different things that have come with it, a lot more people do a lot more testing, the point of care testing for the COVID antigen. That gives a bit of peace of mind to say, okay, at least I'm not dealing with a patient who may be infected with the COVID virus. And then you have other assessments, the chest CT, you've had all that done. So it gives a clear idea. Now, if that hasn't been done, then it means you're going in blind. One of the best things we should do is to actually decide on a room, which is a bit isolated from the rest of the rooms, and then have the door closed and have the procedure done there. However, if that also is not available, the best is to have a room that's well ventilated, windows open, cross ventilations, air moving from one point to the other, and ensuring that the outflow of air is not to the area where there are patients or patient relatives waiting. So that is the best option to use. If you're going to use outside, the question now is, what do you mean by outside? Is it just an open space within the hospital? Would you again be able to protect the patient's confidentiality while performing the procedure? All of the factors are also come into play. So while we are trying to avoid all the other things, we need to remember we're still in the practice, and we need to have a bit of protection of our patients while we carry out this procedure. So options: room without it, without or in fact, you can have the devices which could take a bit of air. They have these mobile devices that can pull in air, have it filtered through the HEPA filter within the device and recirculate it. Not necessarily one that comes with a building. Other option is to have, of course, to always have the door closed. Third option is to have an open room, continuously ventilated naturally with the windows cross-ventilated. The last bit is to use the open space which you have. These are the options which may be considered. Hi, Lizzie.
Yes, thank you so much, Dr. Wahab, for that detailed answer. Next question is directed to Dr. Peters on your presentation. What factors could have enabled the Candida albicans as a cause of the ventilator-associated pneumonia? Over to you, Dr. Peters.
Oh, that's a really good question. The Candida, the patient who had the Candida albicans isolated in his respiratory tract was actually a patient who had been in the hospital for over 80 days. 2, there was a patient who also had acute kidney injury and was being dialyzed. And 3 was a patient who also had CLABSI. He had a central line-associated bloodstream infection with the Candida. So I think that's actually what led to that particular patient's Candida albicans in his respiratory tract. Obviously, the risk factors that we stated in the presentation would increase the risk of a patient getting any organism in his respiratory tract. But as we know, albicans is quite, it's not very common, and it's very difficult to treat. So that patient had to be isolated from everyone else and treated with voriconazole, and he did quite well after that. But obviously the other things that we mentioned, elderly patients, comorbidities, multiple antibiotic use. You can imagine a patient who'd been in the ICU for 80 days, had been, hit with all sorts of different antibiotics. So these are the things that increase the risk factors for the patient to get Candida albicans in his respiratory tract. Hope I've answered the question.
Thank you so much, Dr. Peters, for that. And the next question, I'm going to throw it to any of the panelists. Some of the equipment doesn't need moisture. So how do you go about them when it comes to disinfection? Over to you, panelists.
Okay, Lizzie, hi. I think one of the things we need to understand about the type of equipment present within the healthcare setting is that they come with manuals. Now, when we look at these manuals, there's usually sections that states, specification of types of cleaning agents that can be used, or cleaning processes or disinfecting processes, and in some cases, sterilization processes, which the equipment can be subjected to. It is very important that we read these manuals. I think that's one of the things that I know that a lot of people have not come to terms with. The manuals, in some cases, if you look at the equipment, part A of the equipment may require this type of cleaning agent only, while part B will require a different type, and part C another a different type. So you need to understand the type of equipment you're dealing with. Look at the manual clearly. It gives either a code or directly states in clear the type of disinfectant or agent or process which would be used for cleaning, disinfecting, or sterilization, and then be able to apply it, for each component of the equipment. I think that's the easiest guide. While you say it doesn't need a moisture, I'm sure it's stated somewhere also in the manual about the moisture thing. That's probably how it doesn't require the moisture. Whatever process it requires for sterilization or for disinfecting, you would be able to read it up also or find within the manual as a guide.
Thank you so much, Dr. Abdul Wahab, for that response. Before we move on to the next question, any one of the panelists would also want to possibly add on to what Dr. Abdul has said?
So yes, in our facility, with regards cleaning, so when you talk about moisture, you get the impression that you need to wet something, like apply some fluid. Most of these equipment, for most of them, you can use a universal wipe that has got bleach in it, or chlorhexidine, depending on the solution that is required for that particular equipment. So the equipment doesn't have to be drenched in fluid for it to be cleaned. Everything from syringe drivers to ventilators to air mattresses to the curtains and the poles, every single thing should be cleaned and decontaminated in the ICU. So just like Dr. Etty said, all these manuals, all these equipment have manuals, and it will be stated clearly what sort of equipment, what sort of fluid should be used to clean the surface. So for example, we would use chlorhexidine wipes to wipe the surface of a syringe pump or something. It doesn't leave it drenched in water. It doesn't stop it from doing what it's supposed to do. There's a particular cleaning wipe you should clean the surface with. There's a different thing you should clean the screen with. So if you go through the manuals, like Dr. Etty said, you'll actually see specifically what should be used for what. But the idea is not to drench the equipment in fluid. It won't ruin it. It'll actually keep it clean and still keep it functioning.
Thank you so much, Dr. Peters, for that. Our next question is directed to any of the panelists, or I'll start with Dr. Barasa. On cleanliness, may you please explain on the use of color-coded mops, which color is for which area? Over to you, Dr. Barasa. Hello, Dr. Barasa, are you still on the call? We'll redirect the question to Dr. Abdul. Dr. Abdul?
Yes, please. Okay, so
yes.
The concept of the color coding, I think in itself has different applications. Dedicating different colors to different sections of the hospital is quite key. Having different mobs for different areas, though, of course, contamination levels in different parts of the hospital and different locations. You can't talk about toilets and, of course, a waiting room, to be the same. That's one. Then another thing that's common, which I've observed in a lot of hospitals, especially our public hospitals, is that we tend to have a bucket that has everything in it. There's this sort of I'm gonna add the bleach to the detergent within the same bucket. So I'm having the neutral detergent foaming in a bucket. Then I'm having to add the hypochlorite directly from the concentrated bottles into it and say, oh yes, I've been able to achieve a mixture in one bucket. Again, you could have different buckets for that. Have even different color codes for the different buckets. So you're having your detergent in here, you have the water alone in the bucket, you have the hypochlorite solution based depending on the concentration, whether it's 0.5 or 0.05, as the case may be, in a different bucket color. So all of these would help guide how we make use of it, what content you have with you, which bucket you're using for what, and which areas and parts of the hospital which you use each bucket for.
Right. Thank you, Dr. Abdul, for that. Any additions from the rest of the panelists? Just an addition from my side, it's just to add on to what Dr. Abdul had said, the color coding system is also to ensure that you do not get to use the same mop from one clinical area to the other. There has to be one that is specifically dedicated for your clean areas, that is your offices, and you have your procedure rooms, and then you have one that is for the general ward, which can be of a different color, and then the other color can be for the sluice room. So what you should do is to ensure that it's clearly spelled out on your facility SOPs or hospital SOPs, so that the housekeeping staff know which color to use where. Thank you. Then my next question will also be to you, Dr. Abdul. What can we say is the AGP need for an audit? Over to you, Dr. Abdul.
All right, thank you. So, the question, looks a bit vague, but let me see if I could try to understand what it really means, in the sense that is it that you're trying to act towards the list of procedures that fall under this, which you have to put in your audit plan? Because again, you have to determine first and foremost which of these procedures, which of the procedures in the entire list, as I said, is on an exhaustive list in your own facility that falls under this category. Now, once you've decided which procedures fall under this category in your policy, then you can decide what steps to implement, what precautions to put in place And then you can then have an audit planned to take a look at if this process is take place in a timely manner and when it's due, on what basis, and if all the components are followed. So, okay, so I think that's the easiest way to put, an answer to this. You need to, first of all, decide what procedures fall onto that group and determine what processes, what precautions you would put in place, and then be able to audit if these processes take place at when due. Thank you, Lisa.
Thank you so much for that. The next question is directed to Dr. Peters. To minimize the risk of transmission of ventilator-associated or acquired pneumonias, are special rooms or facilities required? Over to you, Dr. Peters.
So no, I wouldn't say special rooms are required. If you have a patient who is, for example, like I mentioned, the patient who had the Candida albicans, we isolated that patient to make sure that we didn't have an epidemic in the ICU. Obviously, having special rooms, isolating patients in the ICU, having an isolation room is very important. And as Dr. Eto had mentioned earlier, if you negative pressure HEPA filters in your facility, that also helps. We don't have that at the moment. So what we use is we use air purifiers, and we got them after COVID, and there are specifications for it. So in our 4-bed ICU, we have 2 of those units, 2 of the air purifiers. As previously mentioned, obviously we know that some of us are working in resource limited areas, and if we were to say, if you don't have XYZ, then you cannot do, you can't help patients. A lot of facilities might be unable to help patients when they're needed. But the truth is, if we are able to work on our staffing to make sure that, one nurse on each patient, we have adequate distance between the patients in the ICU, we isolate patients who are highly infectious, and we screen patients before they come into the ICU, we would have done a lot of good. But insisting on a special room for all patients probably will not be feasible for every facility. Another thing we also do is that we intubate the patients in the emergency room. Emergency room has 2 air purifiers, and it's very well ventilated. And we make sure that there are no other patients there when we're intubating. Because of all the procedures that we do in the ICU, intubation is probably one of the most aerosol generating of all of them. So the short answer is no, you do not need a special room to prevent VAP.
Thank you for that, Dr. Peters. And before I move on to a next person on the panel, just one more question for you. Taking of tracheal aspirates from ventilated patients in the ICU, does it yield any positive outcomes in terms of identifying the colonizing microorganisms? Over to you.
It does. It really does. We recently got these pulse tracheal aspirate tubes. The procedure to collect the sputum from the patient has to be done in a sterile manner, but it has helped us isolate a lot of organisms from our patients on the ventilator. Definitely. For trickier cases, we will do a bronchoalveolar lavage, but that in itself is another invasive procedure with risks. But we do that if we need to. But getting a tracheobronchial aspirate definitely yields very, very well. But you have to do it in a sterile manner so that you know that your results can be trusted. And using a specialized tubing for it definitely works better than just trying to use a suction catheter and all of that. There's actually a specialized device for that. It's called a pulse tracheal aspirate tube. You get that, you get your result, you get your sputum directly into the container, and you send that off to the lab. Yes, the answer is yes, you will get a good yield from that.
Thank you so much, Dr. Peters, for that.
Amazing.
All right.
Just to add a bit to what you said, because we work together a lot on a lot of cases. The yield, apart from the fact that you do get organisms from gram negatives to gram positives, to even the fungal infections, the Candida albicans, the non-albicans candidas, tropicalis, Candida auris, and the likes. If you take a blood culture in some of these patients also, simultaneously with the tracheal aspirates or bronchial alveolar lavage, we find out that the same organisms are found both in the blood culture and in the specimen. So again, it shows that they are quite representative of the ongoing infections within these patients. So yes, they do give good results.
Thank you so much for the addition, Dr. Wahab. My next question is directed to you. It reads, for a basic minimum requirement of PPE usage, that is a surgical mask usage, during performing an AGP procedure in the absence of an N95 respirator, please kindly advise us on the length of time for usage and replacement of the normal surgical mask, provided the AGP procedure is lengthy. Thank you, and over to you.
Now, this question brings to mind a whole lot of things and challenges that were occurred within the pandemic period. Because at some point in time, or at different points in time, there has been shortage of PPEs, and we've had to consider different ways in which to continue to make use of our masks and continue to reduce the amounts of PPEs consumed. But I think we are past that. However, depending on the facility where you are, it would be nice to work with the IPC team to determine, based on what you have available. Again, I don't know what you have, what type of qualities, and where it is. How long you want to wear a mask. However, of course, once the mask gets damaged in any single way, it's best you immediately change it. That's like the basic, the minimum you can do. Then, if you're going to be present within the space for too long, it's best to wear something that is fitted. If it gets soiled for any reason or gets contaminated for any reason where you have to have it drop off your face or onto a surface, for whatever reason, then it's best to change it immediately. I can't give specifically this period, but I do not expect you to wear it beyond the procedure. If it gets soiled or if it gets damaged at any point in time, you should immediately change it. Between patients, between procedures, that's the best. At least if that's it's available. However, if it's not available, then you're going to have to talk with the infection prevention team.
Thank you.
How you're going to prioritize the mask for procedures which are going to be something. Yes, please. Amazing.
Thank you. Yes, Dr. Wahab, thank you so much for that. And I don't know, Dr. Peters, do you have any additionals? If not, I'm going to hand over to you, Dr. Peters. You wanted to share something with the participants?
Hi, Dr. Peters, we can't hear you.
Oh,
you're muted.
You're muted. I said I just wanted to show what the pulse tracheal culture bottle is. So I'm going to make this. I'm making this now on sterile. So basically, it has a culture bottle attached to it and a tubing. So this goes to the suction tubing connected to the suction or to your pressure on the wall. And this sterile goes into the patient, and you're able to suction. It goes directly into the bottle, and you can send that off for your MCS to people like Dr. Etu.
Thank you so much, Dr. Peters, for that. As our panelists take a breather, I would like to just inform the participants that we've reposted the community of practice link on the chat box. And then I will also get to answer a question about a rollout of the VAP training to healthcare workers. Currently, the training can be organized at facility level through your infection control focal person, or alternatively, if you enroll in one of the ICAN courses, be it the fundamentals in IPC course, the VAP is covered under a module on risk assessment and risk-prone procedures, whereby you not only do you look at the ventilator-acquired or associated pneumonias, you look also at the central line associated bloodstream infections and also surgical site infections, and you cover what we call the bungles of care. So please get in touch with ICAN if it means that the training facilities or capabilities are not currently available in your healthcare facility. And the email is anna at icannetwork.co.za. Thank you. And then the next question is directed to Dr. Barasa. I can see your hand is up. Maybe I should give you time to talk before I ask the next question. Dr. Barasa, over to you.
Thank you very much, Lizzie. I think I had some network issues, but maybe been able to address the Q&A session, answered to the questions or types. So I was a bit concerned by one of the questions that was raised regarding insufficient or shortage of PPEs. And I think it is very important that we really identify which country this is where we are having a shortage of PPEs, because I don't think at this time we should be having utilization of medical masks for aerosol generating procedures. So maybe even like in future, we may consider the issues of, quantification and forecasting, because there have been challenges in terms of having the masks being taken to the last mile to the healthcare facilities that are far away. So I think it's an issue, and we need to highlight which country this is so that we can intensively follow up and ensure that they do have the masks and really address the gaps therein. Thanks.
Thank you so much, Dr. Barasa, for that. If the participant is comfortable in getting to share the country on the chat box, please do so. But if you're not comfortable, we'll post my email and Dr. Barasa's email on the chat box so that you can get a hold of us. Dr. Barasa, the next question was actually directed to you. It's about the disinfection of the N95 respirators. And the question reads, how do we disinfect the N95 respirator, and how long do you keep it on before disinfecting it again? Over to you, Dr. Barasa.
Again, quite a controversial and a difficult question to answer, but very good. And I think for our setting, that would be a bit of a challenge, because with the disinfection, we know that it impairs on the quality of the PPE, the N95 mask, and that can affect filtration and ultimately lead to infection. Additionally, it can also lead to decontamination. It can lead to contamination, self-contamination of the healthcare worker. And that is why I think one of the things that we really need to look into is to ensure that we have routine supply of the N95 masks to all the healthcare facilities. And this challenge is addressed holistically, because from our side, what we are able to see is at national level, PPEs have been adequately being distributed in the countries. But as I said earlier, they're not reaching the last mile. And maybe from the discussions and engagement with One Day and the rest of the Africa CDC team, I think it's good that we look into those challenges of supply chain, etc., so that we can be able to assist our healthcare workers have the N95 masks. Because even with the disinfection that we're talking about, there is impaired quality of the N95, and that can lead to infection. And yet we are saying that this N95 mask should be available to each one of us. So I think it's an area of concern that really can be addressed. Looking at the issues of supply. Yeah.
Thank you so much, Dr. Barasa, for that. It indeed is an area of concern. Please feel free, participants, to kindly reach out to us on the emails that have been provided, so that through the IPC Technical Working Group, where also Dr. Barasa sits in, they can be able to assist you in your various countries. As we round up, I'm going to direct one more question to Dr. Abdul Wahab. May you please explain how you create a negative pressure room? The participant says they have multiple dental chairs in the same space. Sorry. Over to you, Dr. Abdul.
So, thank you, Lizzie. The negative pressure room is something more of an engineering controlled kind of scenario, where it's designed in the building to have the flow of air in the particular direction, so that it pulls in more or less. Now, with a scenario where you have multiple chairs, well, honestly, unless you want to renovate your building, the building that hasn't been designed for that specification from the onset, the best option is to have partitions between your dental spaces, your dental chairs. Have some good partition, and ensure that you have open ventilation if that's possible. Where that's not possible, it means for every single time you're done with the procedure, you might give it a bit of a time, about 1 hour between when you're done with the procedure. You have terminal cleaning done, and then allow for 1 hour to allow all aerosols out, open the doors, windows, and then before you allow the next patient or attend to the next patient. I think that's the other way to be able to deal with that, unless you want, again, as I said, renovate the space completely and have the engineers redesign for that purpose.
Thank you so much, Dr. Abdul, for that. I would also invite any further comments from the panels. And kindly, as we are rounding up, may we try and attend to the open questions that are still on the chat. And just to round up the session, maybe just to give Dr. Peters one more question. Is there research evidence that shows a relationship between endotracheal aspiration and allergies? Over to you, Dr. Peters.
Lizzie, I don't quite understand the question. Is there a relationship between
endotracheal aspiration and allergies? That's
an allergy.
Allergies, yeah.
I'm not quite sure.
Sure, yeah.
I'm not quite sure what they mean. I'm not sure what the question is trying to get at. But basically, no. You're doing the endotracheal aspiration using plastic tubing. The patient would have been intubated with plastic. I don't expect that the patient would have any allergy. The patient was going to have an allergies to the aspiration. They would have also reacted to the endotracheal tube and several other medical devices that would have been put into them in the ICU. If, on the other hand, what the person is trying to ask is if a patient who has allergies, if it will change what the yield will be in from the I don't think so. I don't think that it doesn't have any correlation. No, there's no evidence that's correlated in any way. I'm not sure if I've answered the question, but if I haven't, could you please leave a comment in the chat box so I understand what you were trying to get at to begin with?
Thank you so much, Dr. Peters, for that. At this point in time, I would like to thank our wonderful participants. Thank you so much to our presenters and the panelists, and a big thank you to the interpreters. This marks the end of our session today. And please kindly remember to join us again next Wednesday, same time. And next week, we're going to be, we will have the impact of COVID and IPC on EMS services, on the lab, and also on waste management. So looking forward to have another engageful and interesting session. Thank you so much for joining us today, and we hope to see you again next Wednesday. Thank you. Sorry for the panel. If you still have time, just to hang in a bit, and we finish up the questions that are still open. Thank you. And for the participants that are still having issues with joining the community of practice, we will reshare the link in your emails as we send today's recording and slides. Thank you, and a wonderful day to everyone.